Hey y'all, my name is Taylor Stockwell, and me and my group are going to talk to y'all about streptococcal respiratory diseases and tuberculosis. Streptococcal respiratory diseases are a variety of diseases that occur in the respiratory system and its associated organs, and is caused by different strains of the species Streptococcus. Some of the signs and symptoms of streptococcal respiratory diseases are streptococcal pharyngitis, laryngitis, bronchitis, scarlet fever, and rheumatic fever. The first symptom of streptococcal respiratory diseases is streptococcal pharyngitis, and it's basically when the pharynx becomes inflamed and it becomes really red and it gets uncomfortable. And the lymph nodes are also going to become swollen, and you'll get pus-containing abscesses all over your tonsils. And some of the other symptoms that occur with it are fever and malaise and headache. Another symptom of streptococcal respiratory diseases is laryngitis, and that's going to happen when the streptococcal bacteria spreads to the lower respiratory system, and basically your larynx is going to become inflamed and red, and you'll experience hoarseness, and it's going to make your voice really raspy, and you'll have a sore throat. Another symptom is bronchitis, and it's going to occur when the streptococcal bacteria moves into your bronchioles, and basically your bronchi become inflamed and the airflow becomes reduced. And whenever you have bronchitis, mucus will start to accumulate in your lungs, and you'll experience coughing, and it makes your lungs uncomfortable and you feel a pressure. Another possible symptom of the streptococcal respiratory disease is scarlet fever. And if you get a streptococcal respiratory disease, you won't always show signs of the scarlet fever. Only certain strains of the streptococcus actually cause it because they carry a lysogenic bacteriophage, and the bacteriophage codes for the pyrogenic toxins that actually cause the scarlet fever. If you do have scarlet fever, a rash will start on your chest, and it'll eventually spread across your whole body. And your tongue will become very inflamed and it'll get red, and once the rash starts to disappear, your skin will actually start to fall off. The dead skin cells will fall off. Another type of symptom is rheumatic fever, and it's only going to occur with the group A streptococcus, and it's basically an autoimmune response, and when the antibodies attack the streptococcal antigens, they actually start to attack the heart antigens, and it causes the heart valves and the muscles of the heart to become inflamed. And once rheumatic fever occurs, you're going to have abdominal and chest pain, and you'll have shortness of breath, and you'll get nosebleeds, and your skin could rash up, and you'll also get swollen joints. Due to the many different strains of streptococcal bacteria, it makes Streptococcus a very diverse group. In 1938, the microbiologist Rebecca Lansfield divided the Streptococcus into a bunch of different groups based on their serotype and the bacteria's antigens, and these different groups are known as Lansfield's antigens. Two of the main groups are Lansfield Group A Streptococcus, and the other one is Lansfield Group C Streptococcus. Group A Streptococcus has many characteristics. One of the first ones that causes it to be a virulence factor is that it can cause beta hemolysis. And if you put the group A Streptococcus on a blood agar plate, after about 24 hours, the beta hemolysis will start to occur. The group A Streptococcus has M proteins, and that allows the bacteria to resist phagocytosis. And it also has the hyaluronic acids on its capsule, and that can hide the bacteria from being phagocytized as well. The group A Streptococcus obtains streptokinases, and those break down the blood clots in the body. Another thing that causes group A Streptococcus to be a virulent factor is C5a peptidase, and it's a chemotactic factor, and the C5 peptidase actually breaks down the C5a, which is a protein fragment. And pyrogenic toxins also stimulate leukocytes to release cytokines, and that stimulates your body to have a fever, rash, and it can actually go into shock. Another virulence factor is streptolysins, and they cause erythrocytes, leukocytes, and platelets to lyse. Group A Streptococcus is the strain of Streptococcus that causes rheumatic fever. Another group of Streptococcus is Group C Streptococcus, and it causes beta hemolysis as well. And with the beta hemolysis, it is going to cause streptococcal pharyngitis to occur. And Group C Streptococcus does not cause scarlet fever or rheumatic fever like Group A Streptococcus does. Depending on which strain of Streptococcus and the virulence factors that are present, Streptococcus can cause a variety of different illnesses. And if Streptococcus pyogenes is present, it is a Group A Streptococcus and it infects the pharynx. And if it does, it only lasts for about a week due to the body's immune responses. And it can also cause a sore throat and bronchitis. And if the Streptococcus pyogenes invades deeper tissues and organs, it can only do that by breaking through the mucous membrane, and it causes necrotizing fasciitis.
Hi, my name is Courtney Jones, and I'll be discussing with you the epidemiology, the treatment, diagnosis, and prevention of the streptococcal respiratory diseases. First, I want to talk about epidemiology. Most streptococcal pharyngitis cases occurs in children during the winter and springtime. Staphylococcus pyogenes is spread through respiratory droplets. One person spreads the bacteria by coughing or sneezing within a radius of 1.5 meters of another person. Group A Streptococcus sensitive to antimicrobial drugs but still infects thousands annually. Cases of rheumatic fever declined from 7,491 cases in 1964 to 112 cases in 1994. The decline in strain of Streptococcus that caused rheumatic fever. Next, I'll be discussing diagnosis. Fewer than 50% of patients diagnosed with strepto actually have it, and the rest have viral pharyngitis. Bacterial pharyngitis is treatable with antibacterial drugs, and viral pharyngitis is not. Serological tests are required to diagnose between bacterial and viral pharyngitis. Immunological tests are used to identify the presence of antigens in beta hemolytic strains of Streptococcus. Next, we will be discussing the treatment and prevention of Staphylococcus diseases. Penicillin is only effective against some of the strains of Staphylococcus. Erythromycin or cephalosporin given to penicillin-sensitive patients only. Antibiotics against M protein offer long-term protection against S pyrogenes. However, antibodies directed against the M protein of one strand offers no protection against other strands. It also results in a person having strep throat more than once. Next, we're going to be talking about tuberculosis. Tuberculosis is a respiratory disease that's caused by the infectious agent known as Mycobacterium tuberculosis. Mycobacterium tuberculosis is also known as Cox bacillus. As you can see, tuberculosis is an aerobic rod-shaped bacteria that can only survive in people. Robert Koch was the one who discovered this bacteria in 1882.
Tuberculosis, or TB disease. TB is spread through the air from one person to another. When a person breathes in TB bacteria, it can settle in the lungs and begin to grow. It is caused by Mycobacterium tuberculosis, which usually attacks the lungs. It can also attack any part of the body, including the kidneys, spine, and brain. It can be fatal if not treated properly.
With tuberculosis, there are a lot of signs and symptoms, which are coughing up blood, mild fever, minor cough, chest pain, difficult breathing. You may also have mild fever and wheezing and weight loss as well. Also, in addition with the signs and symptoms, you may suffer from fatigue and malaise as well. Mycobacterium tuberculosis is a pathogenic bacteria due to several reasons. One reason is because its cell walls contain mycolic acid. The mycolic acid is a waxy liquid composed of chains of 60 to 90 carbon atoms. They grow slowly due to the time required to synthesize the mycolic acid. It's protected from lysis once it's been phagocytized, capable of intracellular growth, and resistant to gram staining, detergents, common antimicrobial drugs, and drying out. Also, acid-fast stain was developed to stain mycobacteria. Next is virulence factors. Virulent strains of Mycobacterium tuberculosis produce core factor. Core factor is a cell wall component producing daughter cells that remain attached to each other in parallel alignments. It inhibits the migration of neutrophils. It is toxic to mammalian cells. Mutant mycobacteria that are unable to synthesize core factor do not cause disease. Primary tuberculosis forms tubercles in the lungs. It causes 85% of infections in lungs, which are mostly seen in children. Mycobacterium tuberculosis may remain dormant for decades within macrophages. If the immune system kills all mycobacteria, the body will deposit the calcium around the tubercles, and they are then known as gun complexes. There are 5 stages of primary infection in tuberculosis. The first stage of infection is where the mycobacterium infects the respiratory tract via inhalation of respiratory droplets. Stage 2 is when macrophages and alveoli phagocytize pathogens but are unable to digest them due to bacterium inhibiting fusion of lysosomes to endocytic vessels. Stage 3, the bacteria replicate freely within macrophages and kill them. There are also released bacteria that are phagocytized by other macrophages, beginning the cycle again. This is the stage of infection lasting for a few weeks and is asymptomatic or has mild fever. Stage 4 is when infected macrophages present antigen to T lymphocytes and produce lymphokines. More macrophages are activated and inflammation is triggered. Macrophages surround the site of infection and from tubercules over a 2 to 3 month period. Stage 5. Other cells deposit collagen fibers enclosing macrophages and lung cells in tubercles. Infected cells in the center die and release the M. tuberculosis, producing necrosis. The center could liquefy and fill up with air. If this occurs, it is called a tuberculous cavity.
My name is Natalie Giannini, and I'll be talking about the pathogenesis of tuberculosis. Secondary reactivated tuberculosis results when Mycobacterium tuberculosis ruptures the tubercle and reestablishes the active infection. Bacteria spreads through the lungs via the bronchioles. It is a common occurrence in TB-infected people with suppressed immune systems. Disseminated tuberculosis results when macrophages carry pathogens via the blood and lymph. It is carried to the bone marrow, spleen, kidneys, spinal cord, and brain. Signs and symptoms vary depending upon infection site. The name for TB in the early 1900s was consumption, which refers to the wasting away of the body from the involvement of multiple sites. Now I'll be talking about the epidemiology. Tuberculosis has killed more people than other diseases in history. It averages around 4 people every 1 minute today, mostly in Africa or Asia. It's on the decline in the U.S., but it still affects more than 9 million Americans. 1/3 of the world's population are infected, and over 9 million new cases are seen each year. It causes 1 to 3 million deaths. Now I'll be talking about the risk factors. Diabetes, poor nutrition, stress, crowded living conditions, alcohol consumption, drug abuse, and smoking are all risk factors of tuberculosis. Patients with a lowered immunity are at greatest risk for getting it. TB is the leading killer of HIV-infected patients. Next, I'll be talking about the diagnosis. The tuberculin skin test screens patients for possible exposure to tuberculosis. 0.1 milliliters of the cell wall antigens from M. tuberculosis is injected in the patient's skin. The appearance of hard red swelling at the test site within 24 to 72 hours is a positive test. Reaction is type 4 cell-mediated hypersensitivity response, indicating past infection or immunization but not current disease. Chest x-rays reveal the presence of tubercules in the lungs. Primary TB appears as a tubercle in the lower and central areas of the lungs. Secondary TB appears higher in the lungs. The presence of acid-fast cells and cords in the sputum confirms active tuberculosis. Now I'll be talking about the treatment. Penicillin and erythromycin have little effect on M. tuberculosis because it grows slowly and the drugs are cleared from the body before they have any significant influence. Current treatment is a combination of INH, rifampin, and another drug such as F9B0 or Streptomycin for 2 months, followed by INH and rifampin alone for 4 months. Multi-drug resistant MDR strains of M. tuberculosis is present in several countries. Extensively drug-resistant XDR TB is defined as a disease caused by M. tuberculosis that is resistant in vitro to at least INH, rifampin, and 3 or more other anti-tuberculal drugs. Effective treatment of MDR tuberculosis is very expensive. World Health Organization, WHO, recommends a drug delivery called Directly Observed Treatment Short Course, DOTS, in which healthcare workers observe patients to ensure they take their medication on schedule. Researchers are developing a subcutaneous implant that gradually delivers a drug in the body over a period of months, so direct observation is not required. Lastly, I'll be talking about the prevention. In countries where TB is common, patients are immunized with the BCG vaccine, which consists of attenuated M. bovis. M. bovis is a species that causes TB in cattle and is rarely transmitted to humans via contaminated milk. BCG vaccine is not used for immunocompromised patients because it can cause the disease. Immunization induces immunity in 80% of patients in some countries and significantly reduces the spread of disease. Immunization offers no protection in some countries, such as India. Immunization works in some populations and not in others. In the U.S., cost of mass immunization is not warranted due to the low prevalence of TB. The CDC predicts a downward trend indicating a TB-free country is attainable in the near future.